First, Kelly is going to apply the proper PPE for enteral medications and feedings. So as you can see, Kelly's doing her proper hand hygiene. She's going to apply a mask, gloves, and goggles. The alternative to goggles may be a mask with face shield. Now that Kelly has applied all the proper PPE, she is going to do a general assessment of the client. So she's going to be checking their respiratory status, she's going to be inspecting their abdomen, inspecting the placement of the tube, and if there's any skin breakdown or if the condition of the skin appears to be reddened or irritated.
Good morning, I'm Kelly Parker. I'm an RN working with you today, and we're going to be doing bolus feeding through your NG tube here in your nose. I'm going to check to make sure that I have the correct client. Can you tell me your full name?
This is Mr. Cohn Compa.
Hi, Mr. Cohn Compa. Your MR matches with my paper documentation here. I'm going to assess your nares, making sure that the dressing is intact here. Are you having any nausea?
No nausea.
Any pain anywhere?
And no pain.
Okay.
So the next steps for Kelly to perform is verifying proper placement of the tube. So with Mr. Cohn Compa today, she's going to talk through the proper verification process of the NG tube.
So are you having any respiratory distress? How is your breathing?
No distress.
I'm also going to look here. You could see the markings on the NG tube, so I'm going to check the computer and make sure it's documented at the level and it's still at the place where the computer says it should be located. It goes a little hatch marks up the NG tube.
An additional form that Kelly can use to verify placement other than markers would be aspiration of gastric contents. So as you can see, Kelly's preparing to access the NG tube using a piston syringe. She's going to have a backward force to draw up gastric secretions. And then she's returning the gastric secretions back to the client's stomach.
I'm looking for bile, little pieces of sediment, greenish, yellowish, anything that looks like it could be stomach contents, and that is the aspirate to check for gastric aspirate.
The additional, or probably the most accurate measurement for verification is a chest x-ray, just verifying that the placement of the NG tube is in the stomach. So you could anticipate further reviewing the client's chart to see if that chest x-ray was performed after the NG tube was placed. Do note that PEG tubes or G tubes that are surgically implanted generally don't have to be verified. They were surgically inserted and are placed with a balloon so that they maintain in the stomach. However, you still want to perform your abdominal assessment to ensure that the client is not experiencing any pain or discomfort, along with abnormal assessment data.
So around the PEG tube, G or J tube site, you want to check for skin. You want to make sure it's not excoriated. You want to make sure that this feels intact here. But you don't have to check for placement of this because this is sutured into the site. The reason that we check aspirate here is that this is a tube that's going down their esophagus into their stomach. So if it gets dislodged at all, we want to make sure we're not dumping food, liquid, meds into this because it might not be in the stomach. This can move. This is surgically in place. That's why we don't have to check the aspirate there.
Now that we have verified proper placement of the tube, The client has been receiving bolus feedings, so we need to aspirate for residual every 4 to 6 hours, or based on your institutional policy. So at this time, again, Kelly could demonstrate how much, how we aspirate and then the volume. So generally, you have to follow your institutional policy to see how much aspirate is able to be returned and when to notify the provider if there is a large volume of tube feeding left in the client's stomach.
So what I just did was check for gastric aspirate to make sure this is in the correct spot. When we are checking for residual, the reason we're doing this before we give them another tube feed, before we dump this into the patient, we want to make sure that they have digested what was given to them 4 hours ago. So if this patient received this via this tube 4 hours ago, it went down into their stomach, they should have digested it. So when I go through the same motion like I did before and attach this, and you see how I'm clamping this off so nothing comes out. If I were to pull back on this, checking gastric residual amounts of tube feed in their stomach, and I were to get lots and lots of tube feed and just keep pulling back, having to get rid of it, pulling back, that would mean that something was blocking down here and the tube feed that we had put in 4 hours ago didn't go. My goal is to draw back and not really see anything here, because that means that there's no residual in there and they've digested, and then we can put in their next tube feed.
Good.
So I'm not really seeing any residual.
Very good. So it looks like Mr. Konkomba is able to receive his next tube feeding. So again, we're just going to review the basic equipment that you should have present to administer the tube feeding based on the provider's order. So we should have present the piston syringe, which Kelly has been using and demonstrating right along. The correct order, again, verifying in the medical orders that the client, if they're receiving Gevity, if they're receiving Nepro, that we are administering the correct feeding. And then the water. So we need either tap water or sterile water based on provider order or institution policy. Today we are able to flush with tap water, that's common. We are going to show you the proper amounts of tap water and how to properly use the piston syringe via gravity to administer the feeding.
So I'm gonna fill. There's marks on the side of this. I'm gonna fill it up to like 200 with tap water. And this client has an order for Nepro. So we have checked, we have made sure it's in the proper location. We have made sure they don't already have a stomach full of the last tube feed. And now we're ready to instill tube feed. I'm gonna clamp this off. Always aware of not putting my hands directly into his face or pulling. How much am I putting in?
You're going to put 30 mLs of water into the piston syringe.
So right on the side of this, you're seeing me put 30 mLs.
And as you can see, Kelly unclamped and she's having gravity allow the water to go down. Now, if this was a pediatric client, we would not be putting 30 mLs for a water flush. It would probably be less based on the provider's order, just so that you can have considerations across the lifespan. And now Kelly's going to give the prescribed amount of Nepro. She's going to give 60 mLs of Nepro.
It's not easy, folks.
A lot of hand coordination. And again, as you can see, as she raises it, it can sometimes control how quickly the liquid or the feeding goes down. And as she's doing this, she's keeping track of how much intake she's giving the client. Because remember, we're giving them something that's going into their body, so we have to record it in the I&O section of their chart. Now that the feeding's done, Kelly's going to flush with an additional 30 mLs of water. And throughout all of this procedure, you can see the client is in a semi-Fowler's position so that he doesn't have any risk of regurgitation or an aspiration during the feeding.
I'm holding right where the syringe meets the NG tube. I wouldn't want to hold up here because if they fell apart, all of this would go down on the patient, right? And then it finally gives.
Gravity feeding is the preferred method for the client. It does not force a large volume of gas or food into the stomach and create discomfort.
So now I see that I used 60 of this, so 60 for the flush, and then the additional 60 for the tube feed, and I'm going to put that as intake.
So that was the demonstration of bolus feeding of a client. We are going to verbalize and kind of go through the continuous feeding of a client utilizing a pump. Again, just like bolus feedings, we're going to assess our client prior to administering the feeding. So again, we're going to be reviewing their respiratory status. They're looking at their abdomen, looking at the placement of the tube and the skin condition and if there's breakdown. Again, if it's a continuous feeding or a feeding that's going over a prolonged period of time, we're still going to have to check for residual every 4 to 6 hours. We want to make sure that that food's being digested. The difference that you will find with a continuous feeding pump is that there's usually the presence of a Lopez valve or one of the kangaroo valves that comes with the packaging. And this Lopez valve just allows for a closed loop system. So this valve allows us to be able to give feeding and then an access point to give medications as well so that we don't disrupt the closed system and potentially introduce a bacteria into the gut. So what Kelly just did, she positioned the valve to an off position to connect the new tube feeding line. Now that the feeding line is connected, she can position the off to the side and allow the arrows to show flow into the client's stomach via the NG tube. Again, we will be verifying that we're administering the correct kind of feeding. We would be following the manufacturing for the pumps correct orders to make sure that we're flushing properly, following the physician's orders.
There would be a pump located here. We don't have one over here right now. During the lab, you will see one, and this tubing would go through and you would have programmed it to the correct volume, the correct rate. There's different products. It can come pre-packaged, or sometimes it's in a can and it's poured directly into this bag and that still goes through the pump. If we were to give patient meds,
this is actually our next step in the process. So we have a continuous feeding. You can see the feeding has to slide into the orange piece on the Lopez valve. Kelly's going to use that additional valve to give medications. So we're going to kind of talk a little bit about first general rules, and then we're going to go through how to administer medications utilizing the Lopez valve. So general rules for enteral medications or medications via a tube is that we have to ensure that the meds that are prescribed are appropriate to be delivered via an enteral tube, meaning that they can be crushed or they're in a liquid format that will allow for easy passage. They also need to not be extended release medications or coated medications. So medications that have EC or enteric coatings usually are not allowed to be crushed because it compromises the effects of the medication. Supplies that you will need to be able to perform this skill. You're going to need medicine cups with measurements to pour the medications into. You will need a pill crusher for the medications that do not come in liquid forms. You'll need water to dilute the crushed medications. and a spoon to scrape the pill crusher to ensure the full dose of medication is administered that was ordered. Again, the flush protocol, very much like the bolus feedings, you're going to flush with 30 mLs of water for the adult. Generally, the pediatric is going to be about 5 to 10 mLs of water before the medication, and then you give medication, and then you're going to flush after with water. Okay, so now we're going to walk through those steps together.
So I would have done all of my checks for correct placement before putting any pills in. So I would have made sure his respiratory status was intact, that this marking matched up to what it said in the computer. And then I pulled back to check gastric aspirate, and I saw bile and little sediment, and I knew that it was in the patient's stomach. Then I would have done all of my rites for med administration, and now I'm going to give 1 aspirin.
So as you can see, Kelly's got a multi-dose vial. She's pouring into the cap to get her 1 pill that's ordered, pouring it into the pill crusher, and now she's going to demonstrate proper crushing of the medication. Using that backward and forward motion of the pill crusher to really grind up the med. Now the medication is getting poured and scraped into that medicine cup. And then diluted with water. Now you can see Kelly is stirring the medication just to get it all into suspension. Just like the bolus feedings, the syringe part of the piston syringe comes out. We're just using the chamber part to allow for gravity to flush the line and administer the medication.
I'm going to see how much water I have in here. So after giving the med, I know how much the patient's had for intake. So I'm at like 250.
As that medication's flushing down, now the water, now she can pour the medication in. As you can see, she's swirling, trying to keep everything in suspension so that it doesn't plug the tube. And then she's following it with water again to get everything to flush down. Now, if Mr. Concompa had an order for low wall suction and needed medication to be given in this fashion, we would not be able to reattach the suction immediately after the medication was given. We would either wait 30 to 60 minutes or whatever your institution's policy states to allow for proper digestion of the medication and absorption.
Because if there was a suction canister on this wall and we connected the tube right to this and turned on the suction, it would suck all those meds right back out.
And then understanding that we've given the medication, especially if the client is on feeding. So whether it's a bolus feeding or a continuous feeding, we have to be conscientious of how many medications we're giving, as well as when we can give them. We want to try to optimize the client to not feel so bloated and full. So you want to try not to give them tons and tons of water with feedings and with flushing the line for medications that they get an uncomfortable feeling. Other things to kind of note, if that valve, that Lopez valve that Kelly was demonstrating earlier, if the client has their tube greater than a week, that valve has to be changed so to promote cleanliness and no introduction of bacteria or infection into the client's stomach. The other things to note is that you cannot have feeding running continuously when you're giving medications. You always have to stop the feeding, flush the line, give the medication in the same format that we just did previously with crushing, introducing it into the piston syringe, then flushing after, and then you may restart the feeding after the medication has been administered.